Hi, it's nice to meet everybody. I'm Laura Prolo. I'm one of the pediatric neurosurgeons here at Stanford, and I'm going to talk about von Hippel-Lindau in the pediatric population. So I'm sure everyone's been discussing this all day. I'm sorry, I was in the hospital this morning, but so von Hippel-Lindau, it's a hereditary cancer syndrome characterized by development of tumors, vascular tumors in the nervous system and visceral organs, estimated to be 1 in 3,600 live births. Hemangioblastomas of the CNS are the most common tumor in von Hippel-Lindau, and approximately 60 to 80% of patients will develop a hemangioblastoma. However, in children and patients with the hemangioblastoma, only about 30% of those actually have von Hippel-Lindau. The hemangioblastomas are benign, slow-growing tumors. They do not metastasize to other areas. They're abnormal collection of blood vessels. So you can see here the abnormal blood vessels and capillaries. And they don't exert problems by infiltrating into the brain, but it's more by the tumor growth and the cysts causing mass effect on the brain. And also they can hemorrhage. They represent about 2% of cranial tumors, and they're most commonly found in the spinal cord and cerebellum, as well as the retina. And since this is a germline mutation, hemangioblastomas of the CNS can occur even before birth, and they can be diagnosed very young, at very young ages, even before 10 years old. So this is one patient. This was a 16-year-old girl. She presented with swallowing difficulties and paresthesias in her right arm. So she had a funny vibration sense in her right arm, and then she had intractable hiccups. And normal hiccups are okay, but neurosurgeons always worry if a patient has intractable hiccups that don't go away, that can be attributed to a central problem, like a brainstem function. So she had an MRI done, and this is I don't know if you can see it, but this is her face. This is the back of her neck. This is her brainstem here. And then she has this large cyst in her spinal cord. So that whole cyst is abnormal, and it also had a tumor nodule in it. So she was brought to surgery for resection of that tumor nodule. And you can see now her spinal cord looks much more normal here, and her symptoms resolved. And she ended up doing very well. She went on to college, and she hasn't had recurrence of that lesion. She also had a MRI of her brain, and sort of what Dr. Chang is talking about, she had these little spots in her cerebellum that weren't causing any problems. And she also had cysts in her kidneys and in her pancreas. So again, this brings up similar questions to what Dr. Chang was saying. But, for one, in children, what are the screening guidelines in children? If we see a patient with a hemangioblastoma, what else should we look for? And then what do we do with incidentally found lesions, and especially in a child that has a whole life ahead of them? What do we do if we see little abnormalities on the imaging? This is another patient. This was an 18-year-old, and he presented with headaches, dizziness, and an unsteady gait. And he had a larger cerebellar lesion. It almost looks identical to the Dr. Chang's patient, but you can see there's this enhancing tumor nodule and then a big cyst around it, this dark area. And that is what was causing the symptoms. And he also had hydrocephalus, so he had obstruction of the flow of the fluid in his brain. And that was resected, and his symptoms resolved, and he's doing well 10 years later. So diagnosis, if a child comes in with a hemangioblastoma, first the question is it an isolated hemangioblastoma, or do they have von Hippel-Lindau? An individual with a family history of von Hippel-Lindau and a hemangioblastoma, a few or renal cell carcinoma can make the diagnosis, or an individual with no family history, but they have 2 or more of these characteristic lesions. And then the diagnosis again is confirmed with the variant of the VHL gene. So while most of the manifestations of von Hippel-Lindau actually present in the 3rd and 4th decade of life, you can see here that the most common age of diagnosis for the different disease manifestations of von Hippel-Lindau, there's a wide range of diagnosis. So something like a retinal hemangioblastoma, those can be diagnosed at 12 years old or even earlier. all the way up to 24. Cerebellar hemangioblastomas, the typical age at diagnosis is 18 to 24. And then brainstem hemangioblastomas, spinal cord hemangioblastomas, and the endolymphatic sac tumors, which are less common, the range diagnosis is more like 24 to 36. And so pediatric children, patients are particularly vulnerable at developing hemangioblastomas. And, while these tumors, like I said, are benign, the morbidity from the mass effect can be significant, and they can also have vision loss due to the retinal hemangioblastomas, and they can have hemorrhages if the, cerebellar hemangioblastomas bleed. So it's important to, be able to diagnose them at an early age. This is just the frequency of the different manifestations of von Hippel-Lindau in patients. So retinal hemangioblastomas, cerebellar hemangioblastomas, and the spinal cord hemangioblastomas, again, are more common than things like the brainstem and the endolymphatic sac tumors. This is just briefly the viscera manifestations of the disease, the range of ages of diagnosed for those. So the FEO 12 to 24, and then older ages, the pancreatic tumor cysts and the renal cell carcinoma or cysts. And then again, the frequency of these, the pancreatic tumors or cysts and the renal cell carcinomas or cysts are more common than some of these other things. It's been found that hemangioblastom progression also depends on location of where the tumor is. And so there's this one study that they actually looked at over 200 patients and about 2,000 hemangioblastomas, and they followed them for a very long time. So here, I guess you don't see the mouse, but here, they followed them over the course of 9 years, and what they found is about half of the tumors, they didn't do anything, they just stayed the same. And about half of the tumors actually progressed and got larger. So half of the hemangioblastomas, they never do anything. And then progression also depended on location. So here you can see for the cauda equina and for the spine, those progressed a lot slower than cerebellum and brainstem hemangioblastomas. So depending on where the hemangioblastoma is in the central nervous system might depend whether it's going to do something or just, not change with time. They also showed that the growth of hemangioblastomas is unpredictable, and right now, at least, we don't have a good way to predict which ones are going to actually change and which ones aren't. And so this is another MRI. This is the patient's nose up here, and this is the back of their head, and this is the cerebellum. And you can see they have multiple hemangioblastomas. And looking at the 2,000 hemangioblastomas over these 200 patients, they found that some of them don't do anything. They just stay the same with time and they never change. Some of them increase rapidly and then they stay the same, and some of them just slowly get bigger with time. So it's not really known when you see a hemangioblastoma on imaging, is it going to ever cause problems or not? And that's especially important when you're thinking about kids, because you don't want to do anything with kids. They still, again, have their long life ahead of them. They also found that the male sex was associated with the increase in number of hemangioblastomas and growth rate. In previous studies that they conducted, they found that pregnancy did not appear to impact the development or progression, although this is a little bit controversial. So given all this, the goal is to improve survival and quality of life of patients. And now that we have a better understanding of the natural history of the von Hippel-Lindau associated tumors, there's been a lot of groups that have come up with surveillance guidelines in patients. And again, since it's a germline mutation and you can have some of these things developing even at birth, there's some things that, and I also showed you when the disease manifests in these different organ systems, it's important to start surveilling before there's problems. So, dilated retinal exam to look for a retinal hemangioblastoma, that should start at birth and then continue every 6 to 12 months evaluation. Whereas an HMP by a history and physical by a VHL expert or a multidisciplinary team like we have, that should start at around 1 year of age. They should start getting to know the patients and helping with the surveillance. Blood pressure and pulse at 2 years, metanephrines at 5, And then there's some discussion of the MRI, the brain and the spine. When should that start? You don't want to start that too early for children because then they need anesthesia to get the MRI and there's risk from anesthesia. It's not really worth it if, you're not, it's just to monitor and that you're not going to do anything about it. So, there's discussion of when the imaging of the brain and the spine should start, but somewhere around 11 years old, some recommend a little bit younger, and then maybe every 2 years, kind of also depends what you see on the imaging, the audiology exam, and then the MRI of the abdomen. So this is just, one recommendation for surveillance, but there's a lot of guidelines out there. Again, as Dr. Chang mentioned, the standard treatment is surgery. However, the optimal timing of surgery and the surgical indications remains unclear. Only 6.3% of hemangioblastomas actually become symptomatic and require surgery, so that's something that you have to take into consideration. And while people develop new tumors throughout life, the rate of developing new tumors actually decreases with age. So surgery should be reserved really just for symptomatic lesions, and avoid surgery, especially in children and on asymptomatic lesions. Dr. Chang gave a great overview of stereotactic radiosurgery for hemangioblastomas, and it's especially useful for lesions like he mentioned that are very hard to access, and there'd be a lot of morbidity in removing, except stereotactic radiosurgery in children, it is used, but they also, again, have their full life ahead of them, and there's risks with radiosurgery. So it's, we try to not use radiosurgery as much in children for those reasons. There's different novel drugs to inhibit the pathways or maybe even slow growth of the hemangioblastomas to delay surgery further. And there is promise that they might delay onset of symptoms and delay surgery in pediatric patients. So in summary, hemangioblastomas of the CNS, they're the most common tumors in VHL. They affect approximately 60 to 80% of patients. They're most commonly found in the spinal cord and cerebellum and the retinas. The age of manifestation can be as early as 12 or even younger, and thus surveillance should start in childhood. And surgical resection is the standard of treatment. However, not all tumors are symptomatic or become symptomatic, and surgery should be reserved only for ones that are concerning or causing symptoms.
Thanks, Dr. Prolo. Questions on treatment of brain and spine? Do we have the microphone?
All right, I can be,
okay.
I can be loud without a microphone.
Okay.
So just kind of following on the go-to-take conversation previously with the other colleagues this morning, is there an opportunity to do go-to-take scans for CNS as well to minimize the amount of radiation, or do you still recommend the MRI screening of brain and spine, either for adults or pediatrics?
Yeah, so the MRI, there's no radiation. Okay. Is that what? Yes. Yeah. So this is one thing. Sometimes CT scans do have radiation, and so we really try to limit those in patients. MRI scans, they don't have radiation. However, in children, they might require anesthesia, and so you have risks from anesthesia.
Thank you.
Yeah, and generally, the guidelines are actually just that, they're guidelines, and so I try to tailor the interval follow-ups based upon each patient. So, if you have a patient with a lot of lesions that seem to be changing on the current MRI, it may not be prudent to wait a full year. We may want to get one in 6 months. The patients of mine that have really the most active lesions, I'm doing every 4 months. The patients that have 3 scans in a row on an annual basis that look perfect, and either there's one small lesion that hasn't changed for years and years, sometimes you can even consider going 18 or 24 months on that. So I do try to tailor it depending upon kind of what the activity level of the disease is.
Yeah.
Hi there. Just a question. You mentioned some of those drugs. Would you prescribe those to VHL people? Because so many of us have got these lesions. And, are there any side effects to these? Do they, it seems like, it was just brushed off really fast, and I was just so curious.
Yeah. Part of that is because of my ignorance, because I'm a neurosurgeon, so I don't prescribe the drugs. So I don't know if you've had, I think some of them are a little bit experimental. I don't know if you've used them at all, Dr. Chang,
Well,
or
actually,
someone
one
in
of
the
the
medical.
later this afternoon, some of the speakers are going to actually talk about actually the whole afternoon sessions on drug management.
Yeah.
Yeah. So
I was just sort of putting it out there as that might help delay surgery in some cases.
Hey, thank you both for your presentations. So I understand, like Dr. Prolo said, that the question of whether pregnancy increases the growth of hemangioblastomas is controversial, but it's an important question for a
Yeah.
lot of people, including
sure.
my wife and I. And so I have a couple questions about that. One, why is it controversial? And we're new to, it's a recent diagnosis, so why is it controversial? Is there anything you can say about that question? And have you ever heard of a case of somebody having a surgery on a hemangioblastoma in the CNS that they might not have had, but in order to kind of go through a planned pregnancy, they did in advance? Thank you.
Yeah, so Dr. Ching might know more about this than I do, except, reading through the literature, there's discussion of, do they grow during pregnancy? And if they grow during pregnancy, then what do you do about that while you're pregnant? So at least this group found, they think that actual male hormones might increase the growth, but they did not see that they did not see them grow during pregnancy. So, and that sort of supports their point that it's male hormones, it's not female hormones that might increase their growth. However, other groups, I think there's been other groups that may have found that some of them do grow during pregnancy. And then what do you do about those? So again, I don't know if you have more to comment on that.
yeah, the only thing I would say is, pregnancy can be a little bit of a challenge because usually, before a planned pregnancy, we try to get all the imaging sorted out, make sure everything looks good. But what do you do in a family that's talking about a planned pregnancy where the lesions are not symptomatic, but they're a little bit larger than we'd like to see? Because during the pregnancy, ideally you want to try to minimize number of imaging studies, and that can be a little bit of a challenge. And I suppose in the worst case scenario, during the pregnancy, the patient then becomes symptomatic, and if it's symptomatic enough that requires a procedure, now you're talking about an anesthesia in a pregnant woman, which can be done, but it's just additional challenges. So generally, if someone's having a planned pregnancy and they can kind of give us a rough timeline, we do try to get all the imaging sorted out beforehand. So we at least say, at least at this point, before you became pregnant, everything looked good and stable. And if we have to go for a window of 9 or 12 months without getting imaging, that we feel fairly comfortable with that.
I'm curious about the relationship between the hemangioblastomas and cysts. In my family's experience, it's been the lesions haven't been the problem. It's when the cysts go nuts. And if there's any information on if we know, or if you guys know, what triggers that.
Yeah, there's not a lot of good information about that. Hemangioblastomas, as you're aware, can occur in the solitary non-genetic version. Those almost never have cysts. And then the hemangioblastomas that occur in VHL patients, most cysts that you see with a hemangioblastoma is in a VHL patient. The cysts are difficult to predict because some of them stay the same for long periods of time. The cyst doesn't change on scans, and others the cyst can change very rapidly. We try to factor that in patients, particularly the ones that undergo radiosurgery. There's a small cyst, and we treat the tumor nodule. The thought process is if you kill the tumor nodule, it'll stop kind of weeping the fluid, and the cyst won't grow. But the problem with the radiation is it can take a year or two to kill the tumor. So it's a little bit of a race. Is the radiation going to kill the tumor nodule fast enough before it secretes enough fluid to get the patient in trouble? I have had some patients over the last 20 years where, during that period of time, the tumor is dying, but the cyst continues to get bigger. And some of them have had to subsequently require a procedure to either drain the cyst or remove the lesion if they got really symptomatic enough. So it's very unpredictable. There are some centers that say, well, if you have a cyst associated with your hemangioblastoma, we're not going to even consider radiation. I think that's a little bit short-sighted because a lot of the tumors, you can still radiate and kill them fast enough before the cyst gets into trouble, but it's somewhat unpredictable.
If I could follow up quickly, have you seen, because me personally, I've had the Gamma knife twice. Each time I've had it, within months, the cyst grew rapidly. Is there a cause and effect from Gamma knife and the growth of cyst? Have you seen anything in that regard?
I don't think there's any really published data on that. I think all kind of the high volume centers have had patients like you where you've radiated the tumor and the cyst gets bigger. What's not clear is, would that have happened anyway? Is that the natural history or not? I don't think we're going to know, because we're making a clinical decision based upon symptoms. We can't randomize patients to see, which ones grow as with a control group or not. I think the mechanism by which the cyst formation is also not truly well understood. It's conceptually the simplistic model is the tumor weeps some fluid, and the cyst there. And so again, simplistically, if you assume that the radiation can cause some inflammation and make the tumor more leaky, maybe you can get some more cyst fluid, but I don't think that's been looked at very well. Yeah.
So I may have misheard, but did you say it's more likely that the tumors without a cyst, hemangioblastomas without a cyst, might not be from VHL? So like I had a temporal hemangioblastoma and it didn't have a cyst on it. Is it possible that that wasn't even from my VHL then?
So do you have a diagnosis of VHL? Yeah. So then it's VHL. What I'm saying is that if you look at the sporadic patients, and sporadic mean the patients just with no family history of VHL, one hemangioblastoma, let's say in their brain, and that's it. That's all they have in their lifetime. Those almost never are associated with cysts.
Okay, yeah, I wasn't sure just because I learned that temporal
sure,
ones are
yeah,
so uncommon.
but yeah, that's very rare too. So nearly all sporadic ones have no cysts. In the VHL population, we see cysts with hemangioblastomas, but still in the VHL population, most hemangioblastomas still don't have a cyst associated with them.
Thank you.
Okay.
In terms of MRI frequency and contrast, I know in years prior there was some concern about toxicity from the contrast. Has that largely gone away for the most part?
Yeah, so the question is toxicity from the MRI contrast. So the MRI contrast is gadolinium. It's if you remember from high school chemistry class, it's actually an element on the periodic table. And so I always explain to the patients this is like zinc or copper. It's a gadolinium's a metal. It gets flushed into you via the IV, and the tumors light up. We like it because it makes the tumors light up. Small hemangioblastomas are going to be difficult to see without the contrast. The larger ones, usually the ones that are pretty symptomatic, like the ones that Dr. Prolo showed and I showed that needed surgery, you would have seen those without the contrast. But when you're screening, you're looking for the smaller ones, especially in the spine. It can be a challenge. If you go with a non-contrast MRI because you're trying to avoid the contrast, you're likely to miss newer, smaller ones that are going to be present. So I think the strategy is always a little bit of a balance. That's why, if we have you on a regular scanning regimen, that's one thing. If you're symptomatic, that's one thing. But if a patient just says, I want to kind of look and see, I'm not due for my MRI scan, but I just want to kind of get an idea of what's going on. That's where the issue with the contrast can potentially be questioned. The contrast seems to be very safe. There's been millions of MRIs done. The issue was never raised until about 20 years after MRIs were started to be done. But there is some data that shows that the contrast, small percentages that stick around in your body over time. And so if you had to have 100 MRIs with contrast, some of that 99.99% of the contrast is getting secreted, but there's been a little bit that seems to stick around the tissue.
Has there also been some kind of change with the actual contrast?
I oversimplify things. So the gadolinium is tagged to a larger molecule, and the larger molecules change. There's different types actually, depending on the brand. So some people say, well, this certain molecule shape with the gadolinium is less likely. It's a smaller molecule, less likely to stick around. So there is some of that. Yeah. Oh, yes.
What about with gadolinium in your kidney failure?
Yeah. So.
How often is that in treatment?
Yeah. So, with VHL patients, they often have kidney issues. So, in general, just say it was not necessarily VHL patients, but just patients in general. If you're older, usually over 60, we start screening with the creatinine. But other criteria that you really want to assess kidney function, if they have one kidney, if they have cysts on their kidney or tumors on their kidney, that's important. So that has to get factored in to this. We definitely in a VHL patient, one of my slides was talking about all the disease in the patient, not just focusing on the area that we specialize in, but looking at the whole patient, because you don't want to basically hurt a kidney by ignoring the fact that they have one kidney or a partially functioning kidney and giving a lot of contrast. So you're corrected that if depending on the function of the kidneys, we may have to adjust how we do the MRI scans, and that may limit the amount of data we get from the MRI scans, but we have to balance it with what's going on with the rest of the body.
If I may, again, one more follow-up. But in some folks, with the kidney failure, there's been an extreme reaction to the gadolinium because the body can't process it.
Mhm.
And how many patients have you seen that have that? I think it's systemic fibrosis, dermopathy.
Yeah, I've not seen that ever in my career, but that's part of the issue is at Stanford Radiology. When we put in our orders, they're very conservative here. They will prevent the patient from getting contrast, making a unilateral call on their end. So I've not ever seen that. Have you, Laura?
No, I haven't either.
Yeah, we just Stanford Radiology.
Now.
Yeah. But where were you getting scanned?
It was in Albuquerque,
Yeah.
and there were two different places because my kidney was failing, and so they were monitoring that.
So I've had patients that say, why won't Stanford do my MRI scan? I could, the place down the street would do it, and it's just that we're just more conservative here, for better or for worse. I mean,
Well, I can say not always, but as my husband scanned at Stanford, he developed NSF.
Mhm.
Yeah. Oh, pardon me? Did I? Oh, okay. No, my husband was followed here at Stanford for years and years.
Mhm.
And he developed NSF, but
Mhm.
I think at the time it happened, there was not the connection between gadolinium and NSF.
Mhm.
And once that was done, I know that they started checking creatinine
Right.
before
Yeah.
making sure.
And that's why it's important. And so that's what we try to balance, because we do have patients that want to get scanned sometimes more frequently than we feel is reasonable. And it can be frustrating for the patient because they want to know why we're not ordering the MRI now versus 6 months from now. And that's some of the stuff that we're kind of thinking of. We're trying to figure out, like, if you need another 20 more MRIs in your lifetime with contrast, are we going to be able to get you through that? And what about when you're very symptomatic? If we have a very limited number of MRIs to get, should we be saving it for when we really need to get data to make a clinical treatment decision? So, okay.
thank you everyone for the great questions. We need to move on now so that we can make sure everyone gets lunch on time. But I will pass it over to Chandra, I think.